You got it. Get up there. Go into the cloud. Hi, everybody. You all know me. I'm Cody. I'm a pharmacist by trade and training. I'm a board member on PCCC, the Pharmacist Cannabis Coalition in California. I wanted to give you guys some education and just an update. There's so many acronyms and words and laws, and it's just a lot. And I am not the expert in this. I have my own expertise, but I do consider myself a decent communicator, and hopefully I can just kind of fill you in into some of the current challenges, future road bumps. Um, I don't necessarily have any solutions here for you, but I don't think that I'm necessarily one who has to bring you the solutions. I just wanted to kind of tell you like where we were, where we're going, how we got there, and my little spin on it. I think it's pretty clear if you're here that you think it's important that you're here, but I think that the numbers speak for themselves, right? Within the last year, we've got 15% of Americans, 40 million adults in the United States in 2022 reported last year use. I know for a fact that number is up. The government is just slow. I don't know what it is yet, but I wouldn't be surprised if it was up to 20%, 50 million, something to that effect. Um, the other thing is globally, even considering places where cannabis is a, death penalty type offense, cannabis consumers globally still about 2.5% of everyone and about 150 million people. And that number, once again, is increasing. So let's talk about the system we built, how we got here. Uh, Cannabis began as a medicine. Some individuals were probably growing it for fiber to reinforce pots or to use as clothing. Others were potentially growing it for its rich, nutrient-rich seeds and even leaves. Hypothetically, if with modern technology anyway, you can even grind up and juice the flower, which is being done in certain parts of the country. Perhaps one of my interest or my the thing that interests me most about ceremonial use and historical use is they look to ancient Mesopotamia, so the modern day Middle East, and they have records there in that sort of Asian steppe that individuals, as part of a burial ritual, were actually taking cannabis flowers and cannabis buds and throwing them onto hot coals and then covering themselves and the deceased with a like a ceremonial like a hide or something to that effect in order to essentially create a hot box. And they would do this not necessarily over the dead body. I don't think they know that granular detail, but they would do it as part of a burial ceremony. And it's just interesting that the first hot box was actually an intentional one. They would actually burn hot coals and put it in a wooden crucible. It had a strong resiny smell, so they were also intentionally mixing terpenes with their herb all the way back then. So obviously that's a long time ago and a kind of really confusing history. Kind of during the Dark Ages, cannabis went away, at least as far as Western knowledge was concerned, and it re-entered Western medicine in the 1800s. Hello, welcome, Nicholas. You're admitted. It was started to come back into vogue in the 1800s. What had happened was, as the English physicians were visiting the viceroys and the nobility in India, which was currently occupied by Britain. And so that knowledge trickled back to Britain after sort of the Enlightenment in the 1700s, 16, 1700s. Anyway, fun history. There's a whole conversation and talk to be had. But what we really need to know is it came back and was even in the US pharmacopoeia. It became a Western medicine. But it was from those 1850s until 1942 that modern medicine really started to shift away from plants and plant-based therapies, and there was really push towards standardization and a removal of synthetic drugs. In the 1910s, the US pharmacopoeia was something to the effect of 40% plants. By the time we get down to right here, removed and restricted, 1942. That rendition of the USP was down to about 9% plants. So there was a significant decrease in and sort of stigma against using a plant extract and crude extract as a medicine, but instead you should be using an isolated chemical that maybe came from plants but has been pharmaceuticalized. This restrictions really started with the Marijuana Tax Act in 1937, and then the Controlled Substances Act came much later in 1970. But in between this time, cannabis has a mixed history. It was sort of frowned upon and not frowned upon, and it was counterculture, and then it was outlawed because of that in 1970. Uh, The schedule classification is still going on today. That's why you're here. We have no federal medical access system. It was never established, although starting in 1978, just 8 years after the Controlled Substance Act, patients like Robert Randall, who had been accessing cannabis before or were using cannabis at the time that it was illegal, were arrested, and because of that, they fought back and said, "Hey, this is my medicine, and I have good reason to use it." So there was actually a really, really small and nascent medical cannabis program run by the U.S. federal government as part of the Compassionate Use of Drugs Act or something to that effect. Anyway, Bush number one wrapped that up in 1992 without ever really catching hold. But these individuals, a lot of people know the story about the Nida weed grown at the University of Mississippi and its poor, weak quality. Well, that's the same place that these people were getting their cannabis that whole time. And so you could imagine that it wasn't very high quality. States obviously then attempted to fill the gap. We know how this story goes. California, 1996, and then everyone sort of piles in, and we get this sort of wave of decriminalization and aside medical approval. And so this has left us with these very inconsistent, somewhat limited, and straight up unequal access. And if you don't believe that access remains unequal, I would just remind you that even in the state of California, 50% of all counties still have marijuana illegal, marijuana sales, medical and adult use. You can get mail order, but you cannot have a retail storefront in half of the places in California. And so, like, if we are still at that precipice, this is not equal access to everyone. That doesn't even get into the idea of cost, reimbursement, just health equity as a general whole. We have not established that with medical cannabis. Um, and then, as you know, anybody who's on this call probably has heard of hemp and everything that happened. We're going to get into some of what happened, but hemp came in as the workaround, we'll call it a loophole, even if that might not be the best term for everything that was going on, but a way to supersede sort of these silly rules that have restricted marijuana for too long. And federally and nationally in this country, widely accessible cannabis was everywhere. And I'm not just talking about CBD products. We're talking about synthetic Delta 8 products. We're talking about they're calling THCA flower, which I'll show you a picture later, is marijuana in the truest sense of the word. And we have this sort of loosely defined hemp word that is creating access for everyone, but creating problems in its wake. So the reality, the boots on the ground reality in the US is because marijuana is still illegal. Every state has varying laws for both medical and adult use. And then we threw in the hemp wild card, and it's been really confusing and hard to follow. Marijuana remains federally illegal. It is still a Schedule 1 drug with a high potential for abuse and no agreed upon medical use. That is different than hemp, which in 2018 was taken off that controlled substance list. And anything that falls under hemp, which we'll get to in the future, is no longer illegal. It doesn't really make it legal either, by the way. It's just not illegal. And so national oversight is something that we don't have. There is no one is giving guidance to the CBD manufacturers on what they should necessarily be doing, although, there are guidelines from certain organizations that certainly could be considered as some degree of national regulatory support. But there's no standardized access. We don't have insurance coverage. We don't have workman's comp. There's no safety regulations from a federal advisory. And we've been left to all of the states doing their own thing, which, as you would imagine, has created a patchwork of a system. It's inconsistent. It's obviously fragmented intentionally along state lines, which is kind of an arbitrary, imaginary line anyway, considering some people might live in one state and work in another. And then it is unequal, right? Those people in Illinois do not have access to the same medicine or the quality of Indiana, as those people who live in Illinois. And so, like, even across the simple state lines, there's going to be a dramatic difference. Certain states don't have certain dosage forms. Certain states only have certain approvals for certain conditions, which is, a little demeaning if you think about, like, oh, I'm not approved for this medicine in this state, which we would not say of any prescription medicine. It's not how it works. And so, It's kind of messed up. So, medical versus adult use, we've got these very blurry lines where some states have only done medical, which certainly has provided medicine to countless people. But, it creates this artificial, demand for those medical services when maybe somebody just wants the ability or the legal protection for adult use. And that is not shade or criticism. It's just as much me pointing out that the interests are competing and who are these dispensaries necessarily serving if they're sort of forgetting about these cannabis medicines or these cannabis patients when they're sort of going through their business and deciding what to stock on the shelves, even though those CBD rich products or the minor cannabinoid containing products don't sell as much. It's important to our medical patients that they have them, and the incentives are a little bit broken there. And you would think that hemp, which created a substantial nationalization for access, would have helped solve this problem. Unfortunately, it still seems to be a race to the consumer rather than to the patient. And it came with amazing access and wonderful things. And people, my loved ones have more access to cannabis, and my dog has more access to cannabis, but it came with its own set of problems. Not excluding the THCA flower that we've already discussed, but also synthetic cannabinoids. And once again, the patient sort of being forgotten about because we're pretending that just being able to go to a store and buy something is medical care, and that's not really true. That doesn't encompass all the things that come with medicine and being a healthcare provider, be it a nurse, a doctor, or a pharmacist. So hemp definitely created access, but is going to come with its own set of issues that are currently hitting the market. And that pathway is now being restricted. We are now seeing a closing of the door that was opened up by President Trump and Congress in 2018 and now being closed intentionally by the same group of people. And it's setting up a major shift in what patients can access. So, marijuana is a Schedule 1 drug. Some other examples of a Schedule 1 drug are MDMA ecstasy, peyote, the psychedelic cactus, LSD, which is acid, heroin, which is diacetylmorphine, and then everything under that, Schedule 2, is not necessarily less abuse potential, but the concern is that it does have a currently accepted medical use. So the differentiator here between Schedule 1 and Schedule 2 is not danger, it is FDA approval, in other words, for better or worse. That's just the way that they're interpreting it. So currently accepted medical use for all of time so far since the Controlled Substance Act has meant that it has to have FDA approval. And that is not the case for marijuana at this time. Now, if you notice here, cocaine, methamphetamines, and even fentanyl are Schedule 2 drugs. So these are drugs that do obviously have a high risk potential and abuse potential. I think the statistics, something like 65,000 Americans last year, which is a good year for us, the best year in 5 years, died from opioid overdoses. And these are Schedule 2 drugs. And you can go down the list in reducing severity and risk. You can see in Schedule 3, ketamine and anabolic steroids, which, by the way, are everywhere now, at least in the United States. Very accessible drugs. Schedule 4 or Xanax, Valium, Ambien, a little bit harder to still get. It created plenty of issues. We've got rappers named after the drug, so you know that it at least made its way through the culture. Face tattoos. I think we can thank benzodiazepines for face tattoos in general as well. That's just a personal inside joke. But either way, marijuana remains a Schedule 1 substance where it's been since 1970. But the feds have stopped enforcing this since the Rohrabacher-Farr Amendment, which came into force in 2014, thanks to many people, but our friends at Americans for Safe Access were certainly a big contributor to that. So, after 1970, you would think that people would have challenged this crap because we know that based on everything I just said, all those dead bodies for the opioid epidemic and none on the marijuana epidemic, why didn't this get challenged? Well, the short answer is it did. It got challenged and it got reviewed and it got a study and it got another study and then it went to court again and then they petitioned and blah, 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 blah. It happened numerous times. You can see in 1972. I believe This was actually a recommendation from a federal commission that was trying to look at this after the Controlled Substance Act was passed. People challenged it. They said, "Hey, marijuana should not be lumped in here. Just because the hippies smoke it doesn't mean that it's as dangerous as acid." And they did not take their own recommendation and their own finding. There's a couple other reports, but another big one was even in 1988 when the DEA was looking at this problem and this challenge. They said it was one of the safest active therapeutics known to man, which still tends to be true. The overdose potential is extremely low, but it is not without its own challenges. Multiple rescheduling petitions were denied over the years, but this was never about the science. It was always about politics. And unfortunately, those politics played out and filled jail cells for many years. Despite state laws, federal enforcement is still possible. So even though we legalized marijuana in 1996 or decriminalized it in California, that didn't stop. In fact, raids throughout the United States, arrests, drug busts, and even to this day, we're still seeing illegal marijuana grow ups be enforced in this way. Um, we had all sorts of raids and challenges until 2014, where Rohrabacher Farr, the two Congress people, I can't remember if they're the House or the Senate. I apologize. Um, Senate. There we go. I think. I'm not sure. Anyway, the point is Rohrabacher Farr passed, which was an amendment, and this is important. This was an amendment. This is this bullet two, an amendment to the Criminal Justice and Science bill appropriations. So every year they have to approve the budget for criminal justice. And every year in the budget, there's now a line called a rider, the CJS amendment that says we will not use federal money to enforce state legal cannabis laws. And because of that law, we have been saved from the DEA slamming down doors at our dispensaries in Virginia or any state, Arizona, California. These are all places where this was happening, and it was a real challenge. So cannabis, or sorry, the Rohrabacher Farr is a rider in the appropriations bill. It has to be renewed regularly every time they do the budget, which is every year, every other year. They passed It passed via CJS appropriations this year in 2026, but there is a concern here. This year, they even put out a proposed one that had removed it. Okay, and then when they got pushback, they went ahead and added it back in and said it wasn't intentional to have it removed. But the protections that exist for medical cannabis, and I would note that in this country there are currently zero protections whatsoever for medical cannabis or sorry, for adult use cannabis. The only protections that exist are for medical cannabis here. The CJS amendment is safe for now, but could change any year, and it could change the entire landscape of medical cannabis enforcement in this country. So we've been asking the same question for 50 years. Should cannabis be Schedule 1? The Schaefer Commission said no. The DEA judge said no. There was still, obviously, during this time of legalization from 95 to 2016, the answer was still no. And here in 2024, which we're about to get to, we're still asking. We finally made some progress. And I would just wonder if 2026 could be the year that we finally see this change. Maybe. I'm not sure. People definitely want it, and people are looking for this change. In 2024, Pew looked and asked about medical marijuana. You can see that for medical marijuana, 89% of people think that it should be legal, and 57 think it should be medical and recreational, so adult use, etc. So this is a really impressive number. Um, and I think it expresses a real thought process amongst Americans. I'm not saying cannabis is perfect. I'm not saying we've worked out all the kinks, but this is what Americans want, and I'm pretty sure that's the way democracy is supposed to work. So at some point, it feels like with all of this research and all of this time, that we would get to a point where we could find a way to legalize but regulate. Medical cannabis has overwhelming support. It doesn't matter where you are, age, or political affiliation. In general, it's a pretty positive outlook, although the above 75s are still feeling not so great about it. And you can see that right-leaning individuals are less likely to approve of medical cannabis as well. But overwhelmingly a positive winning issue. We have here the same thing amongst minority groups, amongst age ranges, who's in support and who's not. But it's all basically the same, is that people are in favor of this. They don't think it'll make communities much less safe. Some do. Most don't believe that it's going to increase other drugs or be in negatively impactful in their communities or their criminal justice system. So this is progress. The numbers have never really looked this good for medical cannabis or cannabis in general. So when I say cannabis, you say marijuana. I say cannabis, you say hemp. I say cannabis. No, but what the hell is cannabis in America? We've got these two words and the government defined them. There's no science behind this. These are both cannabis sativa L up here in the corner. These are both the same plant, but they're defined by the government by the psychotropic abilities, how much they can make you high, how much you need to smoke to feel it is weirdly enough where they differentiated it, sort of arbitrarily, and I jest, but seriously, the hemp plant is any cannabis plant that has less than 0.3% THC by dry weight. It can have any cannabinoid, CBG, CBL, anything except for THC. That's all hemp. And it can be super tall and fibrous. It can be big, fat nugs. It can be something that's made for seed specifically, but it's all hemp as long as it doesn't have greater than 0.3% THC, which is generally considered marijuana. Um, Marijuana itself is a bit of a controversial word. No one can seem to agree if it's got racist connotations. There's no doubt that there was discrimination in the history of this plant. I'm not convinced that this word is the biggest challenge we face because of that tainted history. And this is the official word that the federal government uses at this time. So it is the word that I'm using here today. Now, usually marijuana is going to be rich in THC or THCA, which is the precursor molecule. We'll get to that hopefully, I think, next slide. And, cannabis can be used for medical purposes, undeniably, but also there's plenty of people that are using it for sort of adult use, or not adults. I work as a peds hospital. There's plenty of kids using this substance for recreational purposes. Down here at the bottom, you'll notice I did put a little caveat. What's up with indica sativa? And honestly, as of right now, all the data says there's no difference, at least with the current nomenclature. Not to say that indica and sativa don't exist, but that currently they're not being applied to plants accurately to predict effects. So indica sativa, you could have indica or sativa hemp, you could have indica sativa marijuana. Um, it doesn't break down that way. Hemp and marijuana are legal definitions. These are all the same plant. As you can see in the middle of the Venn diagram, they all produce cannabinoids to some extent, although we have made some hemp varieties that produce no cannabinoids. We cut out that enzyme or bred out that enzyme. And they're both medicine. In fact, I kind of mentioned this. I have numerous patients who I work with who are taking hemp medicine, right? Not legally state available California marijuana, but instead medicine that it falls under the definition of hemp and they could buy online. But that's all changing, and we'll get to that in a little bit. Hemp is less than 0.3%. We talked about it. It's widely available. It all started in 2018. This is basically a review here. The federal regulations come from the USDA, the Department of Agriculture, and they're pretty loose. They're not really regulating the product. They're just regulating the growth of the plant. So not really the product that they go into. And there's not too many states that have rigid regulations around what a hemp product looks like in their state. Importantly, there is a new zero point 0.4 milligram per container rule coming up that you need to be aware of. And there's some updates on that coming your way. Greater than 0.3% is marijuana. We talked about it's federally legal, but legal in a bunch of states for both medical and adult use. It started in 1970. These state by state regulations vary and they are tight. So just a little review Venn diagram for to please your eyes, although it's kind of big, honestly. When did hemp become legal? Well, it really started in 2014. This is under President Obama. They allowed licensed research grows aimed at agricultural and industrial uses, but also they were interested in medicine and growing CBD and things of that nature. But this was the really early days. You had to apply to the government to get a special license, research license. Then in 2018, under the Trump presidency, The first one, they passed the 2018 Farm Bill. And keep in mind, the Farm Bill is the same law that is involved in subsidizing corn and soy in this country. It's the same law that deals with milk subsidies and what we pay to dairy farmers. So there's a lot bundled into the Farm Bill. But this is what allowed products to be sold to cross state lines and to not be considered Schedule One drugs. And this really led to a CBD green rush. Everybody rushed in. I even have, a family member of my cousin in Pennsylvania when this happened got a hemp license, and really just thought that there was going to be this really big demand for CBD or for hemp at all, and there wasn't for either. And so this green rush led to a green slump. And so this excess CBD was all sitting around, and people started saying, "Well, what else could we do with it?" And what does the Farm Bill actually say? Well, it says Delta 9 THC. And so what if we make Delta 8 THC? Would that be legal? And the answer ended up being, yeah, kind of. And so that was part of the issues that we came into. In 2024, we were supposed to have a Farm Bill, but we didn't. It got delayed. And then the 2025 got delayed, and they're working on 2026. We'll see what happens. Um, it might even be delayed since 2022, to be honest. I think it's every 4 years from 20. Yeah, it's supposed to be every 4 years. So we're talking about like 5 years extended now. And then importantly, and we'll get to this in a bit, there's an impending access cliff, and nobody's really talking about it, which is kind of crazy. But there's going to be a big change coming for cannabis very soon on November 11th, 2026. All these hemp products, everything containing more than that zero point 0.4 milligram per container, the THC cap that I mentioned there, is technically going to be illegal again. It's going to be a Schedule One drug. So we're rolling all of that back. Again, under the Trump presidency and part of the new minibus, which was what was required to reopen the government in fall. That's where these changes came. They also changed it from Delta 9 THC to Say THC. So there's no more confusion about what the actual definition is. It did also ban synthetic cannabinoids and put some major restrictions on seeds. And this is a challenge as well, and we're going to talk about that in a little bit. Just a reminder, a little science update. The cannabis plant produces CBGA as its primary precursor to um, all cannabinoids that are not beta caryophyllene, which is a terpene. But again, come to a different lecture. So CBGA is the precursor to both THCA and CBDA. Again, most common in marijuana, most common in hemp. Then if we apply heat, either with your lighter or through the oven, we end up getting these neutral forms, THC and CBD, and you can actually further oxidize THC into CBN. Okay? This green step is natural. But this next red step, this is not necessarily natural. And so the question becomes is, is DEA going to, or the new definition going to affect these precursor molecules, these neutral ones, or maybe these even uh, sort of post-processing cannabinoids such as CBN that come from directly from THC? I'm going to speculate a little bit that in a few slides. I also just want to give you a reminder that the FDA knows that cannabinoids are medicine. On the left, you can see synthetically derived THC dronabinol, aka Delta 9 THC, the exact molecule found in the cannabis plant or in the gummies that you picked up at the store. That is an FDA approved drug. It just can't come from the plant. Why? Honestly, there's no good reason. The Delta 9 could and should come from the plant. In Europe, when you get a drug called dronabinol, it is from plants. But for some reason, the history of this drug in the United States, probably the fact that it goes back to the 1980s, it is illegal and it has to come synthetically. Now, you can also get plant-derived CBD now. This was approved in 2016 or 2018, forgive my memory. And Epidiolex is plant-derived CBD. Now, it is highly purified plant extract, so it almost contains just CBD, but there is a tiny, tiny presence of THC and other minor cannabinoids, although they're very closed book about sharing that information with anyone. It's kind of hard to track down. Lastly, on the right, you can see nabalone or sesamet is actually a fully synthetic cannabinoid. You can see down here, it does look quite a bit like THC, but it's got some very particular changes. There's this double bond up here with the oxygen as opposed to this one at the 11 group. And then you've got this extended tail with these two little feet coming off of it. And these are synthetic manipulations, making this a synthetic cannabinoid, not synthetically derived per se. Well, it is, but uh this is where the language gets confusing. Dronabinol, marinol is made synthetically, but exists in nature naturally. Nabalone on the right, this is a drug that does not exist in nature and must be synthesized. Now, we've got all these different states, and every state has a different access variable and so many things to try to consider. We've got millions of patients. This says 3.6 million. I think that's a little low from the Marijuana Policy Project. Uh, 6 million is a I think a more accurate estimate, but there are just millions of Americans, and those are the only the ones participating with these somewhat subpar programs. How many people could benefit from medical cannabis if we rolled it out better, if we did a better job of meeting the needs of patients? I would argue many more. US cannabis reform has been consistent and fractured, and it's a different thing in every little nook and cranny. I can't promise that this map is up to date. It's getting kind of hard to keep to track and up to date on all of them. But most importantly, it is showing the problem, which is that all these different places have totally different rules, regulations, and some of them you can't even cross state lines into there. So a couple different examples of those differences that I wanted to put in there. You can see this map from the Canigma is slightly different than the last map. In California, you can have medical cannabis, but there's really no healthcare provider involvement. And the only thing you need is a recommendation from a medical provider, and that is the end of the healthcare system integrating cannabis into your medical care. And obviously, you can also, since 2018 or 2016 is when they voted, 2018 is when it started, you can get adult use cannabis all over the place, although not in about half counties. Half of the counties don't allow that. Now, California also allows home grow. That's my figure over here. But if we look at Pennsylvania, we've got a very different situation. What we've got is a place that does not allow you to grow at home. That yes, you must see a physician, get their recommendation, and then go see a pharmacist at a dispensary, and recreational use is illegal. And so the reason those two are close to my heart is that's where I'm from, and Pennsylvania's where I'm from, and California's where I live. Arizona's a little bit different too. Arizona's got it's not on the list here, but Arizona's got medical cannabis and now adult use cannabis, but there's no healthcare involvement, and they don't allow home grow unless you live far away from a dispensary, and then they do. So it's really every single place is different. Maryland, yes, we've got these healthcare involvement, medical directors, specifically medical professionals who are serving as the sort of science directors and medical care support services at these dispensaries. And they recently passed recreational use. I don't know where they're at in the rollout. I'm sure it's a mess because they all have been. In Idaho, cannabis is entirely illegal. It's bad. Like there's no tolerance, zero. It's bad. Oh, but wait. What state is Idaho right next to? Oregon, a place that produces more cannabis than anywhere. And did you know that the busiest dispensary in all of Oregon just so happens to sit on the Idaho state line? Wouldn't you figure? Each state has variable access. I hope you got that. This is the 2022 State of the States reports from Americans for Safe Access. I really love their work. I do sit on the board. I'm a little biased, but there's some really great insights here. We are actually reworking the State of the States report now, and we're going to do what we're calling the laboratories of democracy. So if you're on this call, we are working towards that slowly but surely. And Steph Scherer is our fearless leader and just chugs away despite having not enough support. Just really like this work, and it helps kind of frame like we've got a lot of challenges in these states about medical rights, about overall access, about costs, and about a few other things. We have a lot of work to do still. And I'd like to keep medical in focus. When we keep medical in focus, we continue enrollment. The programs tend to be more successful and they perform better. But when we move over to adult use, we see the medical programs really start to suffer. Patient enrollment goes down. Physicians have to step out of being a cannabis doctor and have to go back to their old practices because the demand just isn't there anymore. So this is just one analysis there, just as a reminder that when adult use passes, we do see medical use go down. And I'm not necessarily convinced there's less medical patients. I just think that one, we're probably not delivering very much value as the medical cannabis dispensary. The current model of medical cannabis is not providing enough value to our patients, is probably the number one thing that I would take away from this. That and retail will be happy to take our customers if we're not creating value. But global reform is definitely underway. Look at South America is almost all lit up. We've got a lot of the Caribbean turning green here. Got Central America starting to turn a little bit of green. A lot of these places are starting to loosen up as it relates to cannabis. You can see much of Europe is also trending in that same direction. In Portugal, you've got medical cannabis. And where are we at here? I'm not sure, but there's all sorts of places all over the world. In Australia, there's quite liberalized medical cannabis, and I don't have that on here, but medical cannabis is driven through a pharmacist. You get your prescription, you go to a compounding pharmacy, and it's very much in the sort of traditional pharmacy sense. Just wanted to give you, a global picture instead of the state by state picture. Here you've got Italy as an example. They do not allow home grow, but you can get medical cannabis, and it comes through your pharmacist, not your pharmacist. Sorry, Jill. I know you're scowling at me over there. I can't see your face though. And you get your medical cannabis through your pharmacist in Italy, but there is no adult use cannabis. And I think I should have one more slide on this. Yeah, I'll talk about it next slide. Okay, and then in Germany, you do have medical cannabis, and there's been a pharmacist dispensing that cannabis. You are allowed to home grow, and as of 2024, they legalized recreational use. I believe it's in full effect now, and they're seeing prices go down pretty dramatically, just like we saw here in the United States. Israel, you can't grow at home. Yes, you can get medical cannabis, but it's really not through a healthcare provider. It's through sort of a national service, and there's no sort of continued doctor involvement other than your referring doctor. There's no pharmacist or dispensary or things of that nature. And in Israel, no, it's not recreational, but it is decriminalized. Canada, there, let's go. Yes, there's no healthcare involvement in most of the cannabis ecosystem other than the recommendation. And it's fully legal for anybody above the age of 19 to grow their own or consume cannabis as they wish. There's a bunch of different ways to do this. There's not sort of one country doing it one way. We talked about Canada, which is probably the heaviest home grow country or home grow nation in the world. Uh, but obviously they have dispensaries and stores, and there's even government provided options for patients if they'd like to sort of use their government funds towards an allotment of medical cannabis. You've got the California, very hyper taxed and commercial supply, very consumer packaged goods. Um, and you've got Italy, which I mentioned in the last slide. Italy actually relies on a state supply of cannabis. They have two strains in which they grow, FM2 and FM1. FM stands for pharmaceutical militaire, aka the government's military weed. And the two means THC and CBD, and the one is high THC. FM1 and FM2 is what you're going to get from your government supply and from the pharmacist in Italy. And then Spain, which does have decriminalized, if I remember correctly. It might be medical as well, but they are also allowing social clubs. And so, like there are different avenues to ending prohibition. It doesn't just have to be the feds straight up creating consumer packaged goods. It doesn't have to be all home grow. There's all these different options. And that's what I'm trying to show you here. Not saying one is right or that I've done a great comprehensive job of describing all these markets. Just want you to see, like, we have to get out of our own head and kind of look to the rest of the world and say, hey, what are we doing and what could we be copying? One thing that I think that California is really good at is kind of taking the lead on some more progressive policies. Sometimes I think they blow up in our face and they cost us way too much money. Other times I think we're pretty successful, and I would like to think this is one of them or will be one of them. It's called Ryan's Law. Ryan was terminally ill. He was trying to use medical cannabis in the hospital in California. They told him, no, you can't use that here. Ryan left to the state of Oregon and ended up passing there in a hospital that would allow him to use it. His father came back and pursued creating a law that would allow terminally ill patients to use medical cannabis within institutions, and he did it. He did it quite well. That started in 2021, and by 2023, there was actually an expansion of this law. A couple things here. Marijuana rights for patients. This is for patients who are over the age of 65. So now instead of being terminally ill and being allowed to take a non-inhalable version of cannabis, anyone over the age of 65 with a chronic medical illness, which is almost everyone in this country, qualifies to use medical cannabis as they see fit within private hospitals and healthcare facilities. At that same time, there was also well, I'll leave that out. Anyway, so Ryan's Law in California, I think, is one of these things where we can maybe look to a state and say, hey, there's something interesting going on there. Maybe we should copy that. And then we actually see Marijuana Moment had a nice article on it recently. Numerous states recently kind of adopting and proposing their own version of Ryan's Law. Some of them have a shot to pass, some of them don't. Uh, and in 2015, Georgia passed something called Haley's Hope Act, which allowed patients to go into this low THC registry. So basically, they passed their own version of medical cannabis, Haley's Hope, that allowed 5% or less THC oils to be sold. However, no legal producers or dispensaries occurred till 2019, and we're really just getting things going. And there haven't been very many dispensaries. Georgia's a big place, and there's a very limited amount of licenses. So we've got all this low THC oil. People can produce it, but people can't even go to a store to find it. And so their solution they proposed here in 2023 was that Georgia would be the first state with medical marijuana in pharmacies. So they made a law that said independent retail pharmacies could carry these CBD oils behind the counter. And now you'd have these cannabis products in the pharmacy, which is pretty cool. No one's done this in the States yet. And everyone was excited. I heard a couple people talking about it. And then the DEA came in, shook their finger, and said, "No, no. If you do that, we will try to take your license, and we will consider it a Schedule One drug. Don't do that." So, if you know somebody in Georgia who is giving the middle finger to the DEA, I would love to meet them and be interested to ask them questions. And I'd like to see it. I'd like to see somebody challenge this and see how this plays out in court. Because certainly the state should be allowed to do and move products that are legal to sell out of other institutions within their pharmacies. It doesn't make any sense otherwise. And carve outs like this can happen. You know, pharmacies can be places to drop off controlled substances, including Schedule One drugs. And so it's not like Schedule One drugs never come in and around the pharmacy. Anyway, a couple things in Congress that's just in the mix. I'm not getting into any of these very deeply, but you'll hear about them. There's the Safe Banking Act, which is really focused on banks and allowing more access to money. It's unfortunate, but it's true. You still can't use a credit card in a dispensary because these big money ledgers, these banks, they're not interested in doing anything that could get them in trouble with the federal government. The MORE Act has been proposed before, moved into Congress a couple times, never really made it, to the president's desk or anything. Removes cannabis from the CEA and tried to create a trust to help those most affected by the war on drugs. That sort of mentality is a little out of vogue right now. I would, in general, support most of the acts on this banking act, although I don't necessarily think any of them are perfect. The States Act would change the CSA to protect states from federal enforcement, and so basically give the states the power to write their own Controlled Substance Act, and then they wouldn't need protection from the feds because the feds just cannot override them. So that's one way that people have proposed to get out of all this. And then the Marijuana Freedom and Opportunity Act, the MFOA, that doesn't sound right. Anyway, is would remove cannabis from the CEA and create a tax on marijuana. All of them have been proposed, but none of them really address medical cannabis in any significant way, which is somewhat concerning. And then in addition to that, none of them really have any muster in DC right now. So then, a little timeline here. In October of 2022, everybody got real jazzed up because President Biden at that time began and reignited the descheduling process. Excuse me, the rescheduling process. After more than 40 years of prohibition and marijuana being stuck at Schedule 1, despite that 72 challenge and the 98 challenge and all of the requests, Biden kicks off the actual reschedule review, can be done by the Department of Health and Human Services. And that was great. And in 2024, the those governing bodies, HHS and FDA, came out and said, "Look, we've reviewed everything. We think that marijuana has acceptable medical use." And if you remember, that's what's been keeping marijuana in that Schedule One drug. So in 2024, we brought the drug out of um, excuse me, we brought the drug out of this schedule and or bleh, let me start over. In 2024, the agencies who were tasked by Biden to review the documents reviewed them and said, "Yep, it's accepted medical use." And then they looked at the DEA and said, "Okay, it's your job to reschedule." There you go. And what would this mean for cannabis? Let's focus on the pros because I think those are more exciting. Cannabis to Schedule 3 is codifying what the HHS just found. Cannabis is medicine. And therefore, the DEA can no longer inappropriately keep it in Schedule 1. It has medical utility. So that would be really amazing. Ideally, pharmacies could now carry these cannabis-based medicines. They're Schedule 3 drugs. That's where Schedule 3 drugs come through, although we'd have to have a product approved first, which is not actually done. There is more interest in doing research and funding research if we go to Schedule 3. I do really sincerely believe that. There's just less restrictions, less red tape, less taboo, more buy-in from IRBs. And then for cannabis businesses, they're pretty jazzed because the tax that has been a thorn in their side, known as 280E, targeted at drug trafficking, and sort of gobbles them up in the idea of a Schedule 1 or Schedule 2 drug, is a tax that has been plaguing them. So they're pretty excited. Those would be the pros. The negatives. Just because cannabis is a Schedule 3 does not mean it's decriminalized. And it's not like you're allowed to be carrying other people's Xanax around with you, or if you're caught with anabolic steroids, it's like no big deal. And so yeah, it's not actually decriminalization or legalization. Of course, then there would be restrictions. There would be the 5 month refill, which would create burden and barriers for patients. There are no products currently available, so there would be nothing. Nothing would move immediately because there is no approved product that pharmacies can put on the shelves. Uh, this obviously does not rectify the harms done by the war on drugs and doesn't appropriately reallocate the resources that probably should be. Adult use programs remain federally illegal, so there's no protection existing on the books for any of the adult use that has been established. So it's one of those things where the feds could go kicking in doors again because the Rohrabacher-Farr amendment never applied to adult use cannabis, and now that medical cannabis has been moved into pharmacies, now they can go after adult use. It's probably fearful and not true, but it could happen. And the DEA still has to make this final decision. Okay. Uh, we haven't totally figured all this out yet. So rescheduling then was put on hold. So in January 2025, the DEA canceled the hearings, pushed back reform. Some people think that's a good thing. In any case, we knew that it would be at least 3 months. Well, you don't have to be a rocket scientist to know that this timeline didn't go together. Here, we talk about rescheduling to Schedule 3 again. We resumed this with Donald Trump on the left. This was in December of 2025. Okay, we're back on again 12 months later after January 24 or 25. Here in December 25, we said, all right, executive order, made some rapid changes, and here we are in March and still no changes. But They are letting everyone know that just because marijuana has been rescheduled, that doesn't mean federal workers are allowed to consume them or the drug testing changes. So they're going to limit uh, their employees as well, even though this would be sort of one of the only prescribed drugs where this could be a problem, right? If you are prescribed Adderall, you can work for the federal government as long as you can prove your prescription. And so there are concerns that there'll still be stigma here. But know that Donald Trump has not rescheduled cannabis to Schedule 3. He did resume the process, and we are waiting on the Department of Justice and the DEA. You might be wondering, okay, so is CBD legal? And even the FDA isn't really sure about what the current regulations are. It's legal under the Farm Bill to grow the plant. And technically, the plant and the extracts, as long as it's not less than greater than 0.3% THC, it's not marijuana, so you can cross state lines. But also, CBD is an FDA approved drug, and FDA approved drugs cannot be sold over the counter. But also, it's not formally an herbal supplement, and CBD is not actually considered an herbal supplement yet either. And so we're in this really weird regulatory framework that basically doesn't exist. The existing framework for foods and supplements are not appropriate for CBD. They're going to work with Congress. Well, it's 2023. I assume they're still working with Congress, and based on what I'm seeing, they will be doing so eternally. So, some new constraints on hemp that have come out in this 2026 executive order. This is important. It restarts the rescheduling process. We just reviewed that. But also, this is where we banned synthetic cannabinoids and the list of what is a synthetic and what is a natural and what is high inducing, like THC, was due to be published by 2/10/2026. I apologize. This should say 2026, and it's not published yet. I have heard that the experts have given it over to them, but they have not actually told us what that list is going to be. There's also this new cap of 0.4 milligrams per package, and that is a problem because at 0.3% THC, zero point 0.4 milligrams, the total dosage form has to be less than a gram or less than a milliliter, have to be the whole package at that sort of concentration. So what I'm saying is this is an almost unachievable amount of THC for almost every natural cannabis extract. We'd have to be using isolated chemicals to avoid this cap. Additionally, in this executive order, there are new seed restrictions. And so specifically, they're saying that seeds that come from marijuana plants would be made illegal. So this is seeds that came from a mama plant that produces a lot of THC, which is a pretty hard thing to do considering unless you know the genetics, you can't really put it all together. Or unless you're running genetic analysis on each one of these seeds, which seems unlikely. And then how do you prove each seed in a package is the same? There's just a lot of challenges coming for this. But technically, you should buy some seeds and get a nice place to store them because it is true that they're supposed to be illegal to buy online again starting very soon, which by the way is in direct contradiction to the DEA's open letter in 2022 or 2023 where they straight up said a senior official at the FBI, or rather DEA, excuse me, the DEA went out and published and said no, seeds are not illegal, seeds are hemp. And so it's really confusing. Also, the total definition of THC got changed from Delta 9 THC to all THC, which is going to close the said hemp loophole. So, as I mentioned, the executive order reschedules cannabis and also, more interestingly, is now looking to integrate the Center for Medicaid Services into cannabis medicines. And just a couple days ago on Marijuana Moment, they published this article where they're talking about how they're going to do a new program at it's the Center for Innovation or something to like that at CMS, and they're going to try to come up with this $500 in reimbursement for somebody to buy CBD or THC products. And I was also reading, I think in this very article, that there might even carve out a different limit. So now the over-the-counter hemp stuff, that zero point 0.4 milligram limit that we talked about, is currently slated to be on regular hemp products, but they seem to have made sort of a pseudo medical products saying 3 milligrams per serving of THC in these products that is being covered by CMS. So they're not really covering marijuana, but they're not really sticking to the definition of hemp that they just literally proposed in the very same document. So that's an interesting fun fact. I wanted to let you know that there are a lot of problems that we still need to solve in cannabis. We need other rights and privileges, medical rights associated with cannabis. We obviously need some standardized options. Not everyone wants to smoke a flower. We need consistent access and supply of the novel medicines, the rare ones, the hard ones to find, the ones that don't sell real well. That's okay. The low THC ones, we need access to those products. We need to figure out insurance coverage. Obviously, you shouldn't be kicked out of your home or have your government subsidies for a home taken away from you because you're a medical patient. And unfortunately, that's happening. You shouldn't be labeled a cannabis abuser in your VA medical record and be denied services because you're a medical cannabis patient. And these are real challenges that we still deal with to this day. So, Americans for Safe Access proposes a national medical cannabis program, establishing its own regulatory body, creating a new schedule under a new organization with a law that we've dubbed the Medical Cannabis and Cannabinoid Act. If you're interested in that, I more than welcome you to um, check it out. It's here. You can download the whole PDF. You can download the summary. You can find all of that stuff on Americans for Safe Access website, which is safeaccessnow.org. This is an actual photo of the cannabis industry and regulators' frustrations. And I think we've got work to do. But this isn't an actual photo. But this I thought was funny when I first put this presentation together. And then I made it AI. And I wanted to know if you guys thought that it was A or B was better. I think A was better. It feels more realistic. So anyway, we do have work to do. There's a lot of work, a lot of fight to do. Our group putting on this call today, PCCC, um, is doing a lot of important work in this space, and we have partnered in many projects with Americans for Safe Access. So if you have a few extra dollars or you think this work is important, many of the documents, many of the data all came from ASA. I sit on the board there. I am biased, but I think we're doing really important work. I would hope that you, if you have the means, that you make a monthly donation would be amazing, but a one-time would be great too. That is the end of my pitch there. I do want you to know that I'm on the internet, not just here, but also on Instagram and LinkedIn and all the places. You can reach me if you have questions. I love my colleagues at the PCCC and holler. Now let me know what you think.
I'm just going to give a little more of a shout out to the presentation. So thanks, Cody, for everything. So again, like Cody said, this is brought the webinar or is brought to you by the Pharmacist Cannabis Coalition of California. We are a nonprofit organization. Our website is as Cody has here, the www.pcccrx.org. We do post our recordings and everything else there. So please feel free to definitely access it. As Cody said, if you'd like to donate to make sure we can put on more of these great presentations for everybody for free, feel free to donate. And again, it's been really great having everybody here. Please, put your hand up or something. I think there's a couple, or throw your questions in the chat. I think there's a couple questions for you, Cody.
Oh, I did not check the chat, y'all. I am so sorry. Uh, let's see what you got to say. Let me stop sharing. Sometimes I end up regretting that.
That was great. Thank you, Cody.
Yeah, you're very welcome. I try to just keep it simple, kind of like how I would talk about it. I know I think a lot of this gets really hairy and confusing. And again, without Steph, I probably would be as confused as ever, but I've been listening to her a lot and it kind of rubs off. Um, I am not an expert in this area, is not my expertise, but I do think it's important that people understand what's legal, what's not, how did we get here, what could happen, what are we seeing 6, 8 months down the road. And the truth is we're seeing a lot of turbulence in this industry. Um, and I just don't know that without mobilization, that without grassroots effort, that much is going to change. I will say, and I don't give too much credit to the administration all the time. I would say that there's some interesting things happening. I'd like to see more focus on whole plant, full spectrum, and access that's sort of I don't know. I'd like to see it more medicalized. Right now, it sounds like you're going to be able to sort of buy these hemp products online, but it's possible they're going to end up creating some sort of national database where you can find the products that qualify for reimbursement. I'm not sure what their plan is. They are literally announcing this new CMS plan as we speak. Like this week, it's coming out, and they're going to tell us what the rules and regs are, who qualifies, etc. But there, government integration feels like a natural next step. I don't necessarily feel like it's always good, but it just feels like this is a maturation process that naturally has to happen if we're going to call this legitimate medicine.
I was just going to add, I think the only thing I think we know pretty sure is it's not going to be patients getting directly reimbursed for their products. It's going to be through like a provider or an accountable care organization on the
Yeah, it's probably,
on
yeah, an
the
accountable
stuff.
care organization is the word that I've heard thrown around a lot. And that,
Cody, I
what
have a
does that look
question
like?
from Mike.
Yeah, I see that, Mike. So why schedule six before deschedule? Look, I think in an ideal world, which I have definitely seen we do not live in an ideal world, we would be able to deschedule and things would just work their way out for patients. But patients have been fighting, leading the fight for this plant for a really long time, and I'm not convinced that descheduling it will make it a medicine. I'll give you an example. We don't have prescription saw palmetto, although you did before 1943 when they took all of these plants out of the pharmacopoeia. And so descheduling does not assure that this becomes a medicine that is respected and integrated and thought through. And so by rescheduling in a more stepwise fashion, I think we capture the spirit of descheduling. And in our proposed legislation, we have a full decriminalization of all marijuana laws, period. Not necessarily legalized, but decriminalized. And I think that's really what people are looking for when they talk about descheduling is they want this to be over. No more, telling me what I can grow in my garden, and no more arresting me for having something on my person that's a plant. And so I'd like to see the end to all of that, but I don't think it's politically feasible. And I will say that Steph also feels that way. This is her mastermind plan. But additionally, it just doesn't assure it's medicine. It doesn't mean the insurers will start covering it. It doesn't mean that HUD will start allowing you to have it in your place of living or whatever. They could still create policies and rules around it. Whereas codifying it as a medicine, as Schedule 6, a new schedule, we can start to set up the federal hierarchy we need to have a more sustainable industry instead of 50 different fractures, and kind of top down approach it. Really aiming for what we've been trying to do since the 1970s. The National Medical Cannabis Program has been going on for a long time. You'll still hear Robert Randall's wife talking about it.
I still get just frustrated because in New Jersey, we've had legalization now for a couple of years, and we're still arresting patients. You
And
know,
is it if they have
and
too much, or
the
is it
system has pushed uh, patients under the bus or to the side, um, and now, uh, I just proposed to the governor and attorney general that we move arrests for home grow for patients, registered patients, to the lowest priority that they have. That way, we're not asking for a moratorium from to suspend a law, but just to move it so that someone jaywalking with their dog or the dog without a license is something more important
yeah? And you're
than
talking about patients. These patients, they're allowed to possess the dried flower, but they're not allowed to grow it in their own house. Like that's
Yep,
the absurdity of it all. And we
one
see that.
one plant, 3 to 5 years, $25,000. That's 1 to 10 plants. At
Yeah.
11, it goes up considerably.
All right. Well, let's just say that I would definitely be doing 10 instead of one.
Yeah.
You know, it's like the yeah, I'll take the supersize. I don't need the calories, but if it's only 10 cents, I'll go
I,
bigger.
I've been proposing a 10 by 10 canopy now for a couple of years.
Yeah, I mean, I would love to see that. Personally, I think the government has zero business in our personal gardens. Like, that is my libertarian take. I think it's insane that you could try to say one plant or one fungi is illegal, not even because it's the most dangerous, right? You can grow the dangerous ones that look like the other ones that could easily kill people, and that's fine. It's only the ones that make you feel different.
And, and they're the one, and they're safe.
Yeah, yeah, you're right. You can't actually harm yourself. I mean, I shouldn't say that. You will not die of liver toxicity like
Right.
many other mushrooms.
Yes. You want that from the mushrooms, behaviors, and other stuff.
Yeah, exactly. No promises. So that's the rationale. It is not the only way forward, but I do feel that it is the most politically viable. The appetite in DC is not let's legalize cannabis. It's we got to take it back. We got to go backwards now. Like you can see, Massachusetts is currently under petition to roll back the cannabis laws. I think Virginia has got a proposal to roll
There's a
back their
movement out there.
cannabis adult use. Leia, you're welcome to jump in, but there's many instances where we're in the blowback phase or the rollback phase rather than the push forward towards full legalization.
Sam has still been active.
Cody, actually,
Very
I wanted
active,
to
more active than normal, more active than Asa. I see Sam cranking.
I just wanted to clarify on one point actually. So the I actually work with a group who is working on one of your slides that you were showing about the updated farm bill with the zero point 0.4 milligrams of THC.
Yeah,
The
talk to us, Leia.
clarification is they're going to actually get rid of the 0.3% and switch it for the zero point 0.4 milligrams per serving. It's not both. They're actually getting rid of the 0.3% THC. So that's because, again, a lot of the people in the committee are legal. So I've learned a lot. And pretty much, I guess what the deal was that it was always supposed to be dry weight and no one uses dry weight. So technically the products aren't really legal and blah, 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 blah. So they're switching it to it. But then when I said to them, because we're in a group who is kind of actively trying to fix it, they've requested recommendations for fixing it. This is F3 Collective. And our medical group is actually said to them, we were questioning about the cap, and they said, well, technically, a pill could be a capsule. So, technically, if you give them zero point 0.4 milligrams of THC in a pill, each pill can be zero point 0.4 milligrams of THC. And in my head, I'm just like, that's just so stupid. Just let it was just such a dumb concept, but they have verified that they are not going to be monitoring what a container is. So a capsule is a container, a syringe is a container, but a dropper is not a container. They have verified. So a tincture is a container, but and the 1 mil is not a container. So each individual manufacturer will now have to start separating it into individual doses to put in a package to sell. So it's just very ludicrous. And we're trying to argue that. And the part about the synthetics, our group is helping them get the list of synthetics that should be banned, that have been shown to be dangerous. So just mentioning it, so at least you know that there is medical people making sure that not everything is, that we're banning the stuff that should be banned and not the stuff that we shouldn't be banning, because they are very confused about naturally derived.
Did your group, the S3 Collective, also consult on this list of synthetic, natural, and THC-like drugs?
Yeah, that's what I was saying. Yeah, the
Yeah.
synthetics. Yeah.
And so
So
you've submitted to them your guys' opinions.
definition and list, yeah, too. And they were their list was a little too aggressive, and they really didn't understand. Like I was saying, they don't really. The government doesn't understand plant-based versus not plant-based, and they really don't understand naturally derived versus chemically derived. They just don't get that. So we had to kind of alter it in a way that they would understand better. And sadly, they really still don't get it. So we actually had to come up with a list of not this drug, not this one, not this one. But it's the specific ones that we know, but obviously we have a group of, we have the medical advisory committee with Dr. Bonnie Goldstein, Megan Bang, Dr. Fred Slezak, Brian at Center and RN uh, uh, Golden. Sorry, I apologize. Catherine
Golden.
Golden, and together we've like given them a list of like known harmful synthetics and a definition of what should be considered as synthetic, but they wanted the list still because they just don't get it. But at least, you know, it's coming from medical people, not just being made up by the
Yeah,
like
no,
the
I'm glad that you're there doing that because yes, I don't want the FDA making these decisions.
like the Control Act was originally.
Yeah, that's how we got here.
Mm.
Well, everyone, I really appreciate you showing up here today. As Leia said, this will be recorded. If you have any questions about what I said or didn't say, you can always check that recording. I don't know that it'll go on YouTube, maybe, but it'll definitely be going on the website. And I appreciate your support and the compliments. And yeah, we'll see you at the next education night.
Take it
Oh
easy.
yeah.
Nice work.
All right, everybody.
Thank
Take care of
you.
yourself now.
Amen.